Hey, all right. We just got off a call with well, I'll let you tell him. Dr. Eric Bricker, Joe Wilson.
Yeah, I think we spent about an hour together. We hit on everything from what a direct primary care provider is, what it isn't, where does it work well, where does it not work well. We talked about the market as a whole on just broker model tension. We're like, your competition, a lot of the brokers are not incentivized to even do this kind of model because they work in a shop that just doesn't allow it. We also talked about just the healthcare reality of where we're at. We always talk about benefits, but what about healthcare in general? Where's it going to be in 5 to 10 years with all the consolidation? And I think Dr. Bricker and Joe gave a lot of great insight and value to that. Um, but really, there's just a lot of opportunity. There's a lot of stagnation in the broker community, and with that comes a lot of opportunities for growth for brokers, whether you're in the game or new to the game or have been in the game for quite a while. So I think it's going to be a good episode for everyone to hear. And I would even add, as you guys watch this episode, what you're going to see is Dr. Brooker has been doing this since he was 30 years old, where he has been breaking into the broker community. And so he has seen all walks of life, right? He has seen the winners, he's seen the losers, he's seen the folks that just kind of sat on their books. And in reality, he's now done it so long that he knows how to say, this is what you need to do to be a top level producer and have the conversations with these C-level executives. And so, you might have imposter syndrome, but after talking with Dr. Brooker and listening to Joe, they're going to really give you some golden nuggets that you can really use tomorrow when interacting with an employer, because what you might find out is you might really know more than they actually do.
Yep. All right. Well, let's not give too much away. Without further ado, let's get into the show. Hello and welcome to the Max Revenue Show. I am your host, Trey Shields, along with the Million Dollar Man, Mr. Luke Barry. Luke, how are you today?
Doing great. Happy to be here and happy to have our guests.
Yeah, we've got two heavy hitters today. I'm going to go ahead and read these bios and hopefully not screw them up. Dr. Eric Bricker is an internal medicine physician and former co-founder and CMO of Compass Professional Health Services. Dr. Bricker then went on to found A Healthcare Z, which provides 400 plus healthcare finance educational videos with 130,000 plus subscribers, followers across YouTube and LinkedIn. Additionally, Dr. Bricker serves as the board of directors for Frontier Direct Care. And then with us today, we also have Mr. Joe Wilson, Executive Vice President of Growth and Government Affairs for Frontier, focused on educating advisors and their clients on the benefits of DPC in their health plan strategy, as well as vendor and ecosystem collaboration. He also noted is 2 kids, one wife. Rebecca married 18 years and she keeps allowing me to go have fun, disrupting the market and changing the quality of life for thousands of employees. So that was great.
Yeah.
Um, this is over my skis. So Luke, I'm going to now transition to you and you're running point on this thing.
Yeah. Well, Trey, thanks so much. And Joe and Dr. Bricker, thank you for taking time to be here. A lot of history within this relationship, and really just excited to bring your stories to our listeners. And so with that, would really love to start with just your backstory. How you two got connected to Dr. Bricker, really the reason and your investment in the DPC model and your belief. I know you've gone through some different variations of this, and now you've really landed again with a full partnership with Frontier. But keep in mind as well with our listeners, we've got listeners that may not even know what a direct primary care provider is, what DPC is. And so this is not only an opportunity to educate a couple of thousand young producers and just and employers in general in different levels of HR and just the C-suite, but additionally maybe to help connect the dots with some veteran brokers out there. So again, really excited to have you. Would love to start with just your backstory and how you landed at Frontier Direct Care. And then Joe, would love to hear kind of your story as well. Just a quick 30-second intro of where you guys are headed and just the backstory on Frontier.
Super. Yeah. Well, listen, thank you so much, Luke and Trey, for having me. And thank you so much to everybody for listening. And Joe, thanks for being my partner with Frontier on this call. And so I'm Dr. Eric Bricker. I'm an internist, and believe it or not, I actually used to be a hospital revenue cycle consultant before becoming a doctor. So believe it or not, docs and hospitals have no idea how to get paid. So they hire outside consultants to come in and show them how to do that. And this is back in the 90s, like the internet had just been invented. So a lot of hospital billing was actually still done with paper. And it just, it was a total disaster. Patients were getting like all these bills. It was like totally wrong, et cetera, et cetera. And so I still wanted to go to medical school. And I wanted to have my career try to maybe fix some of the problems, like the financial challenges, because if you have financial challenges, like it impacts your care, right? If you can't afford it, or you can't go to the doctor or whatever, like you're going to get even more sick. So it's a problem. And so I went to Johns Hopkins then in Baltimore for my residency. And I thought I wanted to work as a sort of a policy wonk and doing health services research. And it was just too slow. And so I actually started a health navigation company with one of my consulting colleagues in Dallas, Texas, while I was in residency in Baltimore. And our agreement was is that as soon as I finished my residency, I would move down to Dallas. So myself and my two partners started a health navigation company called Compass Professional Health Services, where we would contract with employers to support their employees and their family members as they navigated the U.S. healthcare system. And that was from 2007 to 2018. And it was sort of hand in glove with the sort of rise of HSA compatible plans or consumer directed health plans, because now employees' deductibles were going up, and then they had these HSA cards, and it's like, well, what do I do as a quote unquote healthcare consumer? I have no idea how to do that. So we at Compass had our own navigation folks that we called Health Pros that would help people to do that. And we grew it to about 2,000 employer clients, about 1.8 million people. It was much bigger than I ever thought it would be. We sold that business in 2018, and I had essentially worked as the sales, marketing, and account management person for 11 years. And so I was actually meeting with HR and benefits consultants and the CFOs, and I had learned so much, and I no longer was beholden to anybody, so that I could sort of shoot people straight. And so I started making these Healthcare Z videos with a whiteboard as kind of a passion project, just to kind of let people know the kind of stuff that I had learned. And shockingly, like literally millions of people have like watched these videos now. I mean, never in a million years, again, would I have thought that people would actually be interested in healthcare finance education, but they actually watch these things. And then one of the brokers that I worked with for a long time, and who watches the videos as well, he had gotten connected with Frontier Direct Care, which is based down in South Texas, and I'm here in Dallas. And so when I met Joe and the CEO, Bib Beal, and Pete Lazapino, who's the head physician that started Frontier, I'm like, this is essentially an even better manifestation of what we were trying to accomplish at Compass. And so it's been a tremendous pleasure and privilege to be able to serve on the board of Frontier. And with that, I'll pass it to you, Joe.
Yeah, no. So his story and background's much different than mine. I was doing nonprofit ministry with an organization called Young Life, if anybody's familiar with that. And so had done that for effectively 20 years. As a consumer of healthcare, I understood that I had a $24,000 a year family plan that I had to fundraise from donors, right, to pay for my healthcare expenses for me and my family that we never used. And I knew that it cost me, roughly only $10,000 to put a whole bunch of kids on a bus and take them to a life-changing week in the mountains that they'd never seen before, and have an experience with, effectively a creator, right? That they could, this was going to be radical. And I'm wasting that away on a healthcare dollar. And we could not have a different option because of just the status of like Young Life employees and stuff like that. Is just, they're young college kids coming out. So they kind of need low deductibles, expensive insurance if they did have babies, things like that. So I understood why they were there, and being international was really challenging. But I just saw that ticket price and I was like, this is crazy. And so when Dr. Pete, who was on my committee for Young Life, and Bib, who was also on my committee, started this company, I thought they were both crazy, because I was like, I'm going to lose some donors here because they're going to go bankrupt or something, right? So I got to help them out. So I was helping with some marketing ideas and things like that. But they began telling me around direct primary care and what it was doing for people and how it could save money. I began using, Pete's services really just as, just a resource. I needed a quick Z-Pack or something going on, talk to him about what's happening wherever I was, and he'd help me get my, meds or whatever I needed, but nothing too exhaustive. And then through that kind of saw, wow, there's something here. This could be really good. why isn't our ministry doing this? And so as that happened, COVID came through at that time, and I was in a good position to take a transition. And I saw the mission field that sat there at direct primary care, really. And being an outreach ministry, it was all about those who were unchurched. When we looked at direct primary care, this was like pre-evangelism of like just getting folks healthy, right? Then they can hear stories of hope, and their minds and their hearts can be changed. And it was like, maybe that's not taking in the full ministry of the gospel, but it is setting up somebody to have a good quality of life and good relationships. And if we could start there, that ministry field looked enormous. And so I was excited to, essentially pick up a sword and start swinging and seeing what kind of disruption we could make to get folks educated and into a DPC model.
Love it. That's incredible. And so, Dr. Bricker, to kind of loop it back to you, that sounds like Joe's inflection point with how he encountered really just the traditional healthcare model and why that was broken before he even really knew what healthcare was. When would you say that happened for you?
Yeah, I first saw that healthcare was broken really straight out of college when I had that healthcare consulting job, and I saw actually how it was broken financially first, and then in patient care in medical school and in residency. And I actually practiced as a physician with a local Dallas hospital system as we were starting Compass as well. And you just saw so much confusion and frustration on the part of patients and their family members as they were, the big three challenges within healthcare are around access, quality, and cost, right? So it's just hard to kind of get in the door and be seen. And um, the best medical care in the world doesn't work if you can't even be seen, right? So I had a lot of patients who they were having a hard time just getting seen, whether it was by a primary care doc or by a specialist. And then in terms of the quality, it's just incredibly variable. I mean, you could have it would vary by one doctor versus another doctor, but in some situations it would even vary depending upon the time of day. Believe it or not, they've actually done studies that found that people were more likely to get inappropriately prescribed antibiotics if they saw their physician at the end of the day instead of at the beginning of the day. Because all the doc wanted to do was go home. So it's like, oh, here's your antibiotics, get out of my office. Okay. So it would vary by like time of day as well. So you had this, it was hard to get into the doc. And then once you did get into the doc, it was like the quality was like all over the place. And then when you got your test or your procedure or your lab or whatever, it's like, oh, by the way, that'll cost you $1,200. Or that'll cost you $1,500. Or that'll cost you, $4,000 out of pocket. And oh, by the way, your employer. And so at Compass, a lot of our clients were between like 100 and 2,000 employees. So it was like Joe's Plumbing or the local like private school or the local church. Or we also had, we actually had professional sports teams as clients. We even had T-Mobile and McDonald's and Southwest Airlines clients. So we saw how these businesses, especially the small and medium-sized businesses, were like, it's basically about $15,000 per employee per year for health insurance. So if you've got 100 employees on a health insurance plan, you're spending $1.5 million. And so literally that's going up by 6, 8, 12, 20% per year. And so I would literally, and at a business that size, you literally were talking to the CFO or the business owner, the CEO. And they were literally like, yeah, like we're like not going to give out raises this year because all the money's going to our renewal on our health insurance plan. Or we're not going to open another office, or we're not going to hire more employees. And so the employees were like stretched super thin because they were understaffed. And they were like, yeah, sorry, we're not hiring anybody else because we're spending $1.8 million on our health plan. We just got an increase for $300,000. And so I saw the financial struggle, both in terms of the out-of-pocket costs for the individuals, but then also for the employers as well. And so, and the reason why I do what I do with Frontier is because all that is unnecessary. It doesn't have to be that way. And there's plenty of companies with their broker consultant that have kind of cracked the code, and people get appointments and the quality is much more consistent and it can be much more cost effective. And so it's like, it doesn't have to be that way. And so if Joe and I can kind of work to show folks that it doesn't have to be that way and kind of paint a picture for what that path looks like, well, then obviously I get super excited about that.
That's, again, incredible. I had the opportunity to work with Compass, and you actually serviced quite a bit of our clientele back in the day. And, with that said, the transition happens and private equity gets involved and things change, with the evolution of care. You mentioned the $16,000 per employee per year number. Rumor is by 2028, we're looking at over $18,000, which is just hard to wrap my own head around. Knowing that DPC, and Joe, I'm going to kick this back to you here in a second, but knowing that direct primary care is the new wave, it is the right way to do healthcare. Like when did you first get introduced to it? Because you were there at the inception of let's really start to almost control the pre-cert of the claim, right? And for those that are just attending that may not know what a pre-cert is, whenever you have a major surgery or something happens, you got to have a pre-certification where they're calling the plan. Compass is really one of at the forefront of helping navigate some of that ecosystem to really develop and drive better quality of care. But if you can do that where your doctor is actually outside of the traditional healthcare ecosystem and they are the tip of the spear, the world's really your oyster. And so I guess the back to my question, Dr. Bricker, when did you really notice or see the need of a full DPC replacement so that you got involved into, the frontier model?
Yeah. And so, one of the main barriers to the access and the quality and the cost is it's frankly fee for service, especially for primary care. So when a primary care doc through your traditional insurance sees a patient, they get paid maybe between like 45 and maybe $100 for that visit. And so the primary care physician is incentivized, and oftentimes they're working for a hospital system, and the hospital system is incentivizing them to see as many patients as they can. And so they spend very little time with the patient. And then they refer the patient to a whole bunch of specialists. You got heartburn, you're going to go to GI. You got sinus problems, you're going to go to ENT. You got a skin issue, we're going to send you to derm. And that created a whole bunch of problems, to your point, around, okay, so one, I saw this doctor for not very long. All of those things could have been taken care of by that primary care physician, but he or she didn't do that because they were just trying to see as many patients as possible. And then they referred me to a whole bunch of specialists who, oh, by the way, I'm going to need to get pre-certification for all the tests and procedures that those specialists are going to do for me as well. And so if you take primary care out of fee for service and do it on a subscription basis so that either the individual or the company is just paying a fixed amount per month, and then the employees and their family members get unlimited use of the primary care physician, then that primary care physician is then no longer incentivized to make the visits as short as possible. Instead, they're incentivized to actually solve the person's problem. Okay. So direct primary care, instead of it be called fee for service, it should be called fee for actually solving the problem. Okay. Which is what people actually
want. Fee for
want.
solutions.
Fee for solutions. A crazy thought.
New
right?
term.
Fee for making people feel better. Okay. Right. And so there is not a primary care physician in America who can adequately treat a patient in 8 to 15 minutes. It's not enough time. And so, therefore, by having it's basically care without claims. And that allows the direct primary care physicians to have much smaller patient panels so that they can see only 8 to 10 patients a day. So they can spend 30, 45 minutes, an hour with a patient. And it allows them to accurately diagnose and accurately treat that member and never generate a claim at all. There's no law that says to see a doctor, you have to generate a claim. Like that law does not exist. Okay. So you can have a subscription to a physician, and that physician can be available via FaceTime or via phone or via text, or you can come into the office. What do you do now? I'll say one more thing. I'll say, what do you do now when you get lab results? Oh, you got to come into the office to talk about the lab results with your doctor. That's crazy, right?
Ridiculous.
Why can't we just talk about the results over the phone? And why can't I then just call in a prescription for your blood pressure medication or your cholesterol medication, et cetera, et cetera? And so it gives physicians and patients the flexibility to interact and the time to interact so that you can do the things necessary to actually, to Joe's point, solve your problem. And the payment mechanism of fee for service through an insurance carrier always got in the way.
Mm.
And so if you remove that and separate it, then that's really where the magic happens.
Yeah,
Yeah.
you're so right on that. I look at the traditional healthcare system as we're either going to the doorknob visit, right? The doctor keeps his hand on the doorknob, and before he even takes it off, he's either referring you, prescribing you, or asking you to come back for that lab visit. And for me, frankly, where my passion project came into this was my father was diagnosed at 41 with cancer. Joe knows the story well, and honestly, it's as sad as this is. It's a story as old as time. um, Ended up passing away at 48. Had to get second opinions along the way. But if he would have had a primary care physician that he was actually having a relationship with, that was able to have deep conversations of what's going on, what's driving his health, family history, I truly believe that he might, maybe he still would have had cancer, but he had had a much of a better opportunity to fight that. And so for me, I couldn't agree more with that model, Dr. Bricker. I've personally seen it change lives, and I know Joe has seen it as well. But Joe, I guess I have a question for you, and back to that $18,000 figure that we're talking about in 2028. Yeah, it's astonishing. Like it's almost, again, like I said earlier, it's hard for me to wrap my hands around it. Knowing that that's coming down the pike, and medical inflation still increasing 8 to 10% every single year, when you're out there talking to brokers and you're talking with them or other folks in the industry, what are people still missing?
Man, that's a great question. I think we come up with the frustration that it is centered around apathy, right? In an HR conversation, it sometimes feels like it's not their money. They're more concerned about the noise of explaining something new to their members, right? Meanwhile, at the CFO or we deal a lot in public sector, the elected bodies, they're just trying to keep everybody happy in a lot of ways, and so that perception that if I change something, I'm gonna I'm gonna lose support and there's gonna be disruption in here and it's gonna make what if it fails, right? And we kind of always say no one ever get fired for hiring Blue Cross, but if you hire a DPC and you miss the mark, like you're probably gonna find a new consultant pretty quick. And so, having those partners to stand up with that, but that is, that's what we see is just that apathy for actually making change or understanding how bad it is, because it's like the boiling frog kind of narrative where it's like it's just gotten hotter and hotter and hotter, and it's like, well, what can we do? It's healthcare. We can't ask questions about it. We don't want to know what our employees are going through, and it's like you should know. You should be supporting them, right? And so how can you support them if you don't know what they're going through? And so having insights to data, things like that, and they go, well, we try to look at data, but our carriers don't give it to us, right? Or we can't see it. And so there's just this like, we have so many other things to fight, distributing our products as a company or doing our day-to-day management as a county or a school district, that trying to go fight this healthcare thing is a whole nother language. And it's crazy that you get in there and you start talking to somebody running a $60 million healthcare spend and they couldn't tell you who their PBM is, right? Like they don't know how this actually works. And so they know they had to buy one, they know they had to pay one, but they couldn't tell you why or what's different from this one or that one or any of those things. And so I think just getting them to a space in which they're not apathetic has been the thing that has driven that change. And that takes poking the bear a lot in the boardroom and kind of saying, do you realize you're paying more for healthcare every month for your employees than they pay for their own mortgages? Let that sink in real quick, right? And so, would you rather provide for them a house or some insurance they might use once in a while on some drugs they don't need, to maybe get a little skinnier here? So, this is the conversations we have to start having, that they start going, well, let's think about that. Like, what can we do? Well, we could do both things at once and take care of them, get them more care for less money, and be more efficient about finding those solutions. And the quality of life goes up. And the engine of your entire company is your people, and their health is their motor, right? So let's tend to that first. And now the distribution of your products and the management of your services gets a lot more efficient because you got happy people around you. That's what changes it, is selling that emotion, helping them understand that they can have a change maker stand alongside them, and they're now on mission to help their employees, not keep them from accessing that care because it costs too much. And we change that mentality to go, let's drive utilization proactively, quickly, and get to the root causes of what's going on. And we watch that healthcare dollar get way more efficient and go a lot further for these companies and these employees. And so putting them on mission, questioning their apathy around their willingness to change, and then calling their vendors to the table and saying, we're sharing data. Why aren't they? And that's been the thing that they kind of start looking around going, you can share data. You're choosing not to. I think I'm going to find a new carrier.
Joe, with a mustache like that and the ability to drive culture with a speech that you just gave, you're going to go far in life. I just want you to know that. Hey, so
Thank you.
on that, let's just take a deep dive into DPC. Like what I would love to do is kind of just kind of dispel some myths, and then also just talk about just education around that. And so, kind of starting with the end in mind, where, and Joe, this is for you, and we will work our way back, Dr. Bricker. But does DPC work, and where does it not? Like you said, school districts. I know, Joe, you and I've been down to Harlingen, Texas, and we've had a lot of great meetings down there, and we've also have had some that have not been so great. And you live and you learn,
Heartbreak.
but we've also seen where it works and where it doesn't. So just from your point of view, like let's just land the plane there real quick.
Yeah, and it's that is a multifaceted question. So, I think there's strategies in which you can use other DPCs. There's DPC networks, depending on the ROI that you're trying to get or the dramatic change you're trying to install. Our target market is a geographically centered employer that usually probably has 500 lives on their plan or more. And so we're looking for that municipality, that school district, that manufacturing place, because it is about getting to the brick and mortar clinic and having access to that within, let's say, 30 or 45 minutes is kind of our threshold, right? Because I'd rather spend 30 minutes driving in my car to have an appointment with no wait time and be seen, right, than 3 hours in a waiting room, even though I only had to drive 5 minutes. And so we make that kind of real clear, but that's a good place for that to work. It works for fully insured and self-funded just the same. It's just a matter of understanding how you're kicking the can down the road with your financing on a fully insured plan, right? And attacking that medical loss ratio. So it works in a multitude of insurance strategies. But if you're, let's say, the one question we often get is, hey, I'm, a large employer. I've got 500 people in this market, and I've got 30 that are working in Tupelo, and I've got another 100 that are working in Nashville, but my 500 people are working mainly here in Memphis. What can we do? And that's where the consultant really has to take an aggressive strategy and say, hey, we can, center your critical mass around this really great advanced direct primary care, and they can take the bulk of it and, do this. But for that tertiary market or whatever, there's usually a DPC out there that's an independent direct primary care. They're usually doing like retail patients or, smaller companies. Even those without insurance that are just providing the care, partner with them, send those 30 or 40 employees in that part of town to that clinic until really those larger at-risk models can saturate a market, and then they're able to serve the corners of that city or get out to those tertiary and secondary markets as well. So like in the Valley, right, we've got critical mass, 10 clinics. We're able to really kind of branch out and serve multiple employers and multiple insurance plans in that model. And we can take in small groups and large groups because we're not always trying to build a new clinic. For new DPCs trying to scale, that's harder because they got to go find that 1,000-person group to warrant, swinging hammers and hiring doctors in a new market. And so it's a challenge. So we're having this maturing of the independent DPCs that can still serve those nooks and crannies real easy for a small employer, but the advanced primary care, model that comes through as an advanced direct primary care that can go at risk and do the patient navigation and help with direct pharmacy relationships. That's a whole different game, and that's kind of where we've gone. But there's still a lot of viability in those smaller markets for independent DPCs to be as part of that strategy.
Yeah, and sadly, I don't think you would disagree, but part of the biggest roadblocks that you've experienced, that I've experienced, are the brokers, right? They're the traditional brokers that are there where they might see that, but it's also going to hurt their compensation on how they're structured. And that's the reason why you probably only work with a handful of brokers in each different marketplace. And so, Joe, you had mentioned savings too, like driving those levers of savings. Dr. Bricker, when we're talking about the economics of this, where do the savings actually come from? Like in a traditional DPC model or an advanced DPC model, like Joe was saying, where is the employer going to see the savings? And I would say too, if the employer is seeing savings, the employee and the families are going to see savings as well.
Yeah, 100%. So I'm sure many of your listeners are familiar with the 80-20 rule. And so healthcare costs fall within the 80-20 rule, where 80% of the healthcare costs for a plan are driven by the 20% of plan members that are, typically considered like higher cost claimants. They're generating in excess of $100,000, $50,000, maybe even down to $25,000 of claims in a year. And the biggest driver of high cost claimants and high cost claims for an employer sponsored plan is hospitalization. So hospital costs are through the roof, and it's because the hospitals have raised the prices so dramatically much. And so when you have 24/7 access to a primary care physician and have long visits and have the opportunity to have your care then coordinated by that primary care physician, so that even if you do go to a specialist, your primary care physician is playing quarterback and making sure that all your medications are not interacting with each other, et cetera. What happens is it dramatically lowers hospitalizations and ER visits. So literally Frontier has seen for self-funded employer clients, their hospitalizations drop by 40% and has seen their ER visits drop by 70%. And so a lot of groups are like, hey, well, our ER costs aren't that high. You got to understand that 80% of hospitalizations start out in the ER. So that's how employees and their family members are getting into the hospital, is through the ER. So you need to decrease the ER visits as a mechanism for decreasing those hospitalizations. And so you're really lowering your overall healthcare costs by decreasing those ER visits and hospitalizations. In order to achieve that level, the utilization of the clinic, and this is the key, okay, it really needs to be in excess of 40 to 50% of the plan members. And so this is where the out-of-pocket cost for the actual employees and their family members to use the clinic is $0. It's free. Okay. You don't get rid of your regular health plan. You've got your Blue Cross, United, Cigna, Aetna, what have you. Our customers don't get rid of their health insurance carrier. We're just saying, look, for your primary care services, there's zero out-of-pocket cost for you. If you still want to go, a lot of women still want to go to their OBGYN, which is totally fine. And then maybe they're pregnant and they have, labor and delivery at the local hospital. That's all going to run through the plan like normal, as it should. And they're going to have deductibles and copays and co-insurance for all that. But for the primary care services, it's free. And Frontier actually pays for the generics for the employees as well. So all their generic medication is free too. And then Frontier actually sets up contracts with specialists and will refer our patients to those specialists. And when Frontier actually sends one of our patients to a gastroenterologist for their colonoscopy, et cetera, then that referral to that specialist is also free as well. And for the employees, they're like, so I have a $2,000 deductible or I have free. And so that really drives a lot of the utilization, because of course people want to use the free option. And so it's, Rome's not built in a day. We don't expect to have 40% utilization in the first 2 weeks. No one would ever expect that. But over the course of the first year, you can get up to 40% utilization. And by the end of the second year, you can even get up to 60 to 80% utilization. And you need to achieve that level of utilization to cast a broad enough net so that you're capturing those potential high-cost claimants and preventing them from ever needing to go into the ER or the hospital at all, which is why primary care and direct primary care is really superior to this whole quote-unquote prior authorization approach, right? Because with prior authorization, the train's already left the station, right? They might already be on the OR schedule for next week. And it's like, well, can we get approval? And it's like, no, that's the wrong time to be engaging a patient, right? You got to engage them much earlier when they're just forming the relationship with the doctor. And so on so many levels, the engagement and the relationship and frankly, the superior care then decrease the high cost utilization, which lowers the overall plan cost. Literally, we have plans that have seen their trend go from 6 to 8% increase to actually a 10 to 15% decrease, and then remain flat after that. So anyway, long-winded answer to your cost question.
Well,
No,
I want to.
yeah.
I want to add something to what you said real quick, because this is the no loss revenue piece. Like when brokers think about, how am I going to lose revenue by introducing direct primary care? And the reality is not, right? Because you still have your traditional health plan stack over here. If you've got a, stop loss, TPA, PBM, and if you're, in that position, that's, and you're consulting with those, let's say you're taking commission on each of those products, you still have that commission over here. So that's still going. On top of that, there are, commissions or overrides or whatever that people have in those plays that they can make sure they got that. But really what we would encourage you is to like take what you're making and then go to your client and go into a consultant relationship where it's like, I'm not going to take commission. That's a perverse incentive in the market in a lot of ways, because I'm only going to show you what's going to pay me the most. Let me just tell you what it takes for me to service your account transparently. And maybe I need to make more because I'm going to bring in more strategies. So here, I'm going to up it a little bit and I'm going to bring in all this stuff, but we're going to do it where I sit on the same side of the table as my client. The other part is even in a fully insured, solution there, you're still selling that fully insured plan and you're selling DPC alongside it. So it's actually a second product to bring in that could drive more revenue for your house essentially as you go forward in that. And more clients coming in mean more revenue too. So you're going to have solutions that are actually going to market with products. The second thing I'd add to too is Dr. Ricker was talking about the care navigation, right? I'm at the TPA conference right now. And there's this thing where we think, oh, we've got all of these things happening at the TPA level for care navigation. There's no better place to navigate your patient than at the point of care. When the doctor's looking at them in the room, it's not a second phone call we got to make from an 800 number that I don't know this person who speaks in a different accent than I do, and I'm supposed to trust them on where to go. That's a challenge to go drive that navigation that way. But when the provider that has a relationship with you is doing that point of care navigation, so you can actually streamline some of those resources. And even as we engage hospitals too, a streamlined ecosystem model where they're not having to go through all the noise in the ER, but actually have the right surgeries coming to the right places expeditiously like that. There's actually an efficiency to be gained here that profits everybody.
Yeah, absolutely. I think it comes down to the question of who's paying you, your client or the carrier, right?
Yeah.
And I say carrier, it could be any kind of vendor that you have in that stack. And so, when I hear you guys say this model, I'm just reminded that, the carriers had this figured out during the ACA. I know we've talked about the MLR rule, the medical loss ratio, and really what's driven that. And it's just fascinating to see since the dawn of the ACA, your Blue Cross, United, Cigna, Aetna's, they've all outperformed the S&P 500.
Oh
I
yeah.
mean, I think United Healthcare now, not to pick on them, and again, I've got employers with United Healthcare and they know who they're dealing with, but United Healthcare was the second best performing stock behind Apple over this last decade, and they own, I think over, Dr. Bricker, correct me, over 10% of all US physicians now. So, they're doing their job for their shareholders. But the question comes back to who's really who as an employer are you paying? The carrier with the shareholders or an outside broker consultant that's sitting on the same side of the table as you?
Mm-hmm. Yeah.
Hundred
And I think it's
percent.
important.
Yeah. So how we'll close this out on this side. And now what I really would love to do is kind of get into some broker model tension and just really walk through some of the and even from Compass on Dr. Bricker, like how you've seen the broker model change and shift and really you're always going to have winners and losers with disruption and it's going to be you jumping on or jumping off that bandwagon. But before we get there, I guess the last question I have on demything or debunking any myths with regard to DPC is how should employers think about integrating DPC into a broader health strategy goal? And let me give you an example. As we meet with employers across the country, there's this idea of the race to the bottom dollar for administrative cost. And I feel like part of my job as a consultant is to almost challenge them to say, I think you're thinking about this the wrong way. The question should be, how much more should I be spending in administrative cost, right? To address the 80% that are my medical claims and RX claims. And so when we talk to employers, I always joke when we're doing our big claims review and we're talking about claims, I would always pause and say, would you be mad or happy if I said your number one largest claim driver was primary care? And they all, without a doubt, always say, well, that would get rid of all of our problems. And then I would say, well, let's put in a DPC model. And they would go, whoa, that's too much of an administrative expense. I don't know if we could afford that. We've got 1,000 employees, we're talking, it's too much work. And then the excuses start to come in. But in reality, again, as you guys have said, if we can implement that right on the front end, then yeah, primary care should be the number one most frequent claim driver on the plan. And that is actually a good thing when that happens.
Yep.
So when you're talking to employers about a broader health plan, how do you think they should adopt that from a mindset perspective, getting them outside of this traditional buyer's mindset?
Yeah, so it's a great question. And so this is interesting, is that really as a best practice that, like large, sophisticated employers that frankly that have hundreds of millions, if not over $1 billion of healthcare spend on the line, it's interesting. They will actually bonus their HR and employee benefits employees based upon hitting the overall budget for the employee health plan, claims and administrative cost combined. And so they're like, look, our claims going to be high? Is administrative costs going to be high? We're putting them together and you've got a budget, okay? And you need to come in underneath that budget. And if you come in underneath that budget, you're going to earn your bonus. And so as a best practice, what those employee benefits departments have done is they've actually increased their fixed costs, what some folks might consider their administrative costs, because they found that the decrease in claims has more than compensated for the increase in administrative costs. At a very basic level, as a best practice, the employee benefits departments have more employees themselves. They have a lot of the internal expertise because a lot of HR departments and employee benefits departments, they're tremendously understaffed. So they just don't have the capacity to be able to effectively run the plan to decrease claims. So you're kind of cutting your nose to spite your face. And so one of the best practices is actually to expand your team. Okay. One of the classic examples of that is Purdue University. Purdue University has kept their employee health plan trend at 1%. So instead of trending at 6, 7, 8%, they've trended at 1%. Guess how many people are on their employee benefits team? 26. They've got 26 people. Okay. And you're like, yeah, I only have 500 employees or 1,000 employees or 250 employees. Yes, you don't need 26 people, but there's companies out there that have employee health, to Joe's point, that have an employee health plan spends of 10 million, 20 million, 50 million. They got like one person. Like it's way too small. And so when you increase your fixed costs, in fact, and the carriers know this too, because what they do is they bury administrative costs as claims. And so you're like, oh yeah, your administrative costs are so low. It's like, yeah, because they're putting it in the claims. And you're like, oh, I don't look at the claims, or I can't even get access to my data to even see the claims, right? And so there it is unfortunately, it's not always the HR department's fault. Sometimes it's finance who said, like, look, we're going to have two separate budgets. We're going to have our claims budget and we're going to have our HR admin budget. And so they even measure them separately when they shouldn't. So as a best practice, your employee health plan needs to be run like a business. That's what every single head of benefits and CHRO has ever told me, is that you have to think about your benefits plan as a business. And if you can do things to increase your fixed costs that will more than compensate by decreasing your claims cost, then as a business, that's a smart business decision, right? If you go from 10 million down to 8 million in total spend, but your actual administrative costs went up, was that bad? Was that a bad business decision on your part? I would say no. And so what's happening is that more and more employers are, to Joe's point about complacency, is that it's very sporadic. There are parts of the country and there are industries where, frankly, they are not complacent because they don't necessarily have the top line revenue, or they don't have like the tax base, if you're a municipality, to be able to pay for this. And so it's very spotty, but there are absolutely pockets where employers have said, hey, we need to take on this challenge. And they've adopted those best practices, or they've found consultants that help them adopt those best practices. And they've totally made it work. Like anybody who goes in this direction, you're not reinventing the wheel. Okay, this has already been done before, and you can follow what these other. So I'll give you one last example. There's a credit union in Kentucky with 115 employees that's self-funded, and they cut their employee benefit spend in half.
Wow.
115 employees in Kentucky. Okay, so believe me, if they can do it, you can do it.
100%. I just find this so fascinating, and it's almost just kind of makes me angry when I'm talking to some of the C-suite executives that we meet with. And I always say this too, like you can't deliver A-level strategies to C-level C-suite players. Like they're just not going to be able to wrap their head around it. But yet you have your second largest line item of expense behind payroll that you can't control. And if that was any other part of your business, you would fire that vendor or get rid of that team and build up the team that you need in order to have a sufficient business. So to hear you say, to run it like a business, I just hope more and more employers catch on to that in the middle market because they can do it. And in fact, we've seen it even with smaller groups, the smaller, like even sub 50, where they've been able to pull this off. And they have more of a sniper like approach to this, more so than some of our largest clients with 5,000 plus employees on the plan. It's just fascinating. And so I think you always said it too. There's not, this is all, you're not reinventing the wheel here, right? Something that I am seeing in the market that I'm really passionate about is there's no such thing as a secret sauce anymore. There's just not. All the information's out there. It's how you articulate it and provide value to the client. And so on this, really had a quick question for you. There's obviously structural tension between the brokers and the healthcare system. Trey, you got a question?
Yeah, real quick. I think Joe wanted to chime in real quick.
Oh, sorry, I didn't see that.
I forgot what I was going to say. Move on.
No way.
The ADHD is going real quick. Yeah, I hit it, and I was like, yeah.
He hit the raise hand button, and I was like, Joe's got something.
Yeah,
no way you forgot. That's great.
It'll come back in a minute. We'll be good.
Look, go on. Broker tension.
Yep.
Save us.
Yeah.
So again, there's no secret sauce in the industry, but yet there's this broker tension where everyone's trying to hold everything really tight to the chest, and this is our secret sauce of how we're going to deploy the strategy. And really, it's brokers hiding behind big brands and not really truly educating themselves on the value prop that they actually have access to. And so when you're seeing that in the broker community, what are you seeing where, even if you're at a big box shop or a smaller shop, where are you seeing advisors actually get it right? Like, so if you're in my shoes and you're a broker that's been in the game 10 years or 5 years or even 2 years, and they're listening to this and they've got all these ideas that are 100% accessible to them, where are you seeing the good guys do it the right way?
I think, first and foremost, and I've been a part of the conversations where it's like, hey, not this year, we're switching out TPAs. Not this year, we're going to shop stop loss. Like, you're missing the cornerstone of your health plan, right? And so it's like and we think about it this way, right? If you go procure care, then you can then procure insurance at the appropriate value level, right? You can understand your stop loss thresholds, things like that, right? So as we kind of look at that, it's like procure that care first, and then you find the TPA and the PBM partner that's going to bring in transparency alongside you, that they're going to understand the overlap and decide like, hey, maybe the TPA isn't the best place for care navigation because the DPC is doing it here. So the business rule is going to be that the DPC does the navigation first and then leans on these national contracts that TPA might bring to the table or this wrap network on the back end. And so if they can structure that right and actually understand how the patient journey would go from start to finish and how those businesses can overlap and collaborate together, then those are the brokers and consultants that are really doing it right. But it takes a change management attitude and education to say, we're going to workshop with these people for maybe 3 or 4 months to get them wrapped around it. And I would think about it this way. And here's what I was going to say. And I raised my hand. And we had that famous line we'd always hook, which was GM, spends more money on healthcare than they do steel, and Starbucks coffee beans. They spend more money on healthcare than they do coffee beans. But I can tell you what, when they go procure coffee beans, they send a team to go find the best coffee bean and how it's grown and know everything about it. But we're not procuring healthcare that way when it comes to that. If we put that kind of intentionality on that same line item, maybe it'd look a lot different. And so having an advisor and a consultant that brings that strategy of let's go talk about and learn how to procure healthcare with direct primary care as our foundational cornerstone, those are the ones that win.
So, Dr. Bricker, on that note, and Joe, that was a great comment. I'm glad you raised your hand and chased that
Forgot
squirrel.
and brought it back.
Yeah, I love that. I love that. So
It's a
you
gift.
said something on change management. Harvard Business Review wrote a really great article. They have several times over the course of the last few years on how change management is just so difficult for organizations. Um, with this, how do employers determine the difference between noise and guidance? Right, because there's an adoptive rate here that you talked about on utilization, but it is also change management. And once you answer that, I'd love to go and kind of close some things out on just really just healthcare from a macro reality. So short answer, short thought on that. We'll kind of jump to the next phase.
Yeah, and so I've really seen younger brokers and producers that have smaller books of business go out into the marketplace and really grow their books of business by bringing fresh ideas and newer, better solutions that are just not carrier based. Like literally, there's a broker in Travis that when I started Compass, I was 30, and he was a producer. I think he was like a year older than I was. He was 31. And he dramatically grew his book, not just with things like Compass, but with other innovative solutions. And really the key to his success is that in an employer space, right, they're always going to have the pain of the high healthcare costs. And so when Travis was bringing in the solution, or when a young producer brings in a solution like direct primary care, what they're looking for is a catalyst within that organization that's causing change, right? So what is that catalyst? Sometimes it's a change in their head of benefits. Sometimes it's a change in their head of HR. Sometimes it's their change in CFO. Sometimes it's the change of the business owner or the CEO. We've seen big changes in employee health plans when the father who started the company passes it on to the son. There's a huge huge Chevy dealership here in DFW where that totally happened, where the son became the COO of the car dealership, and he was like, "We're getting into our health plan. And Dad, you did a fantastic job growing the business, but we're gonna do something about this health plan here. This is crazy." Okay. And so what a young producer is looking for is they're looking for those catalysts within those organizations. And so you got to knock on a lot of doors because you can't force the catalyst, right?
Mm-hmm.
And so you're looking for that. And then if you find the catalyst, then you can go in there with your wedge of, here's a direct primary care solution that's going to perfectly fit in the environment that you're in right now where you're looking to make the change. So if there's anything that I would tell a young producer, it would be you got to knock on a lot of doors, and you just have to have a lot of conversation. This really is a numbers game. You got to just talk to a whole bunch of folks. And if you talk to a whole bunch of folks, you will find those organizations that have some sort of catalyst occurring, which is really the opportunity for you to then bring in the value.
100%. And I would even say, to extend that, if your employer does not allow you to do that, you might be at the wrong employer, right? If they're not allowing you to be creative and innovative, you might find another ship to jump on. And they're out there. So I would just encourage those producers that might be struggling with that. To kind of close this out on our little last segment, let's widen the lens and talk about what's actually happening in the healthcare system. So we've talked about benefits, we've talked about all these lovely strategies and really how to deploy DPC, what it is and whatnot. But Dr. Bricker, where do you see, really two questions. What are the top 5 cost drivers? Doesn't have to be 5, but just what are some of the top cost drivers you think we're going to see in the next 5 to 10 years? And the side question to that is also going to be with the consolidation that we've seen in PBMs, hospital systems, the lack of, some of these physicians in certain states are deserts, right? Missouri is one of them. Tennessee is really close to it. Arkansas, same thing. Where do you see the cost drivers rise? And then 2, with all this consolidation, what's going to happen?
Yeah. And so the reason why healthcare costs are rising is because prices are rising. It's not because the overall utilization of healthcare services is rising, right? Because just, very basic economics, it's, overall healthcare cost is the price of an MRI times the number of MRIs that your employees are having. It's the price of a surgery times the number of surgeries that they're having. And so what's driving the cost isn't that they're having more MRIs or that they're having more surgeries. What's driving it is that the prices are being increased the unit cost is being increased for each one of those services. And to your and so that's connected to your point around consolidation. This is where hospital systems have consolidated the local independent physician practices such that they're no longer independent. They're now employed by, or they're a joint venture with the hospital system. And then those hospital systems themselves are actually merging together as well. It's happened in a number of states, including the ones that you just mentioned. And so this is where I say, like, capitalism without competition is exploitation, right? What allows any business in any industry to raise their prices? Oh, if they raise their prices and don't lose their customers. Well, why would you not lose your customers if you raise your prices? Well, if you didn't have any competition, right? If you're a gas station and you raise your prices, guess what's going to happen? Everyone's going to go across the street to the other gas station, right? So the overall inflation will likely get worse if you continue to use the traditional healthcare system through a traditional insurance carrier. Okay, so just know that unfortunately, like we have to confront reality. Like, I know it's hard, I know it's a lot of work, but and I'm not saying anybody's an ostrich and just sticking their head in the sand, but it's not the problem is not going to go away on its own. Okay, and so if you basically look at the supply chain for your employee benefits and for your healthcare for your employees, like, you can piece by piece re-engineer that supply chain to deliver much better care at much lower cost and not be subject to the whims of consolidation and price hikes that are just going to kill your plan.
What a word. What a word. Joe, anything to add to that?
No, I mean, I think that sums it up pretty well. I mean, I think the other fight that we're in here is when you consolidate, and let's just be honest that medical providers out there aren't in the marketing game. They don't go sell direct to employers. So the one place they get paid is through the carrier, right? And the carrier is in this competition with 4 other markets saying, hey, join our network. You think they get that network joining by saying we're going to pay you less than the other guys? Like, so that just constantly compounds up because all the incentives are misaligned. And we know that from, Health Rosetta and those things that they say and teach a lot. And so learn about where those incentives lie. I love the Charlie Munger quote, right? Show me the incentives, I'll show you the outcomes. And hey, the incentives are right in front of you. We've got shareholder profits and an economy to drive, right, on this machine that we live in over here in the US. And so as that goes forward, it's got to drive that revenue. And right now it's getting out of healthcare. And it takes an educated buyer to get out of it.
Yeah, no, so true, so true. I want to thank both of you for just taking an hour out of your time to be with us. I do have one final question. This is more for an employer, but if you're sitting across the table, not as a broker, but just in your role, from a CFO, a CHRO, just a C-suite person in general, and they feel stuck, right? They don't trust the conversations they're having with the broker community, right? They've seen the consolidation on that end, and they're tired of a new business card coming in every other year, and you've got a bunch of new brokers that really may not know what they're talking about as they come in. We call it parroting, right? What would you tell them first to do? Like, what would be the first thing you said? Hey, I know you're stuck. You're having these issues. What's their first next step?
Joe, you go first.
Okay. I mean, I think the first next.
Don't say partner with Frontier Direct Care. You got to let this be your lead out comment.
Yeah. I mean, I think first is align your incentives. I think getting into that consultant contract where it's hey, you work for me and I'm asking you to go procure on my behalf, and you're not going to take commissions out there from the market, right? You're going to take your performance from me. And then having the people in that ecosystem put their fees at risk in some way, right? Performance, whether that's bonusing them for a job well done or penalizing them, for not meeting the mark. There's carrot and stick there, but figure out how you want to align that so the incentives are aligned first. And then I think the second biggest thing would be to push for transparency. And if somebody in your ecosystem isn't willing to share line level data on what they're paying out of your checkbook, like, fire them now. Like, don't wait, don't pass go, like, get rid of it, make the change as fast as you can, and get to players that want to share the data so you can actually have insights to understand what your employees need and deliver a care strategy that answers those questions. And now you're paying fee for solution instead of fee for service, right? So that's what we want to get into, is providing those solutions with aligned incentives, procured care that we're taking on with transparent data.
Dr. Bricker?
And I would just say, if you are within HR, like, go ahead and like make sure you're always evaluating your options in the broker consultant space. And if you are a CEO or a CFO, like, make sure your HR department is constantly evaluating in the space. And there is again, as a best practice, you should not have the same broker consultant for 20 years, right? That's a problem. Okay, if you have the same broker consultant for 20 years, you're actually probably doing the wrong thing, not the right thing. Because even if you do keep the same broker for, let's say you keep him for 5, 10, 15 years, right? If you're constantly comparing them to the marketplace, then you're going to be able to get that enforced broker to give you more of what they should be giving you because you've shopped them to the market. And, so like you gotta hold people's feet to the fire. And the brokers that respond to that and deliver great service, they win. I've always seen them win.
Mm-hmm.
Mm-hmm.
Love
Absolutely.
it. Trey, anything you want to add to close us out, my friend?
Nah, I'm just blown away. This is incredible. This is, this side of the house, a whole new conversation for me. And so I'm just, they say if you want to, what is it? If you want to sound stupid, just open your mouth. So I've tried to just be quiet. So I'll turn it back over to you.
Well, Dr. Bricker, Mr. Wilson, we really appreciate your time. Again, huge fans of what you guys are trying to do. Thank you for working with me the last almost decade, I guess now, and trying to live out what I'm trying to do. And I look forward to the next 10 to 20 years. And hope you guys have a great day. And our listeners, hope it was well worth the listen.
Thank you guys. Thank you
Thanks,
so
Luke.
much.
Thanks
Thanks,
for
Trey.
having us.
Appreciate it.
Yeah.